Good morning, everyone. I'm Mickaël Ohana from Strasbourg University Hospital in France, and I'm really delighted to be virtually with you at the winter course of ESTI. And today we are speaking of a subject that I hope by mid-December would be not as severe and not as important as it is now when I am doing the recording in mid-November. And the question we will try to answer today is CTPA in COVID-19 patients, luxury or necessity? Let's go back to the beginning of the pandemic in France, and the first COVID-19 related death was reported by the end of February. And at that time, it was quite striking because when you look back at the news from the death, it is mentioned that the patient didn't die of COVID-19, but of massive pulmonary embolism. And at that time, it was thought that this was not a complication related to the virus. By mid-April, we published simultaneously with our colleagues from Besançon 2 research letters in radiology stating a very high rate of positivity of CTPA in COVID-19 patients. In our publications, the rate was 30%. In the publication from Besançon, the rate was 22%, so unusually high. And currently, by October and November, we are amidst the second wave of COVID-19 in Europe, and I think it's the case in the whole Europe now. And basically what we are facing with our colleagues from the ED or our colleagues from the ICU is that whenever they have a patient with a suspicion of COVID-19, they do not ask for simple chest CT, they ask for CTPA. And the question is, should we do CTPA for every patient? When we go back to the first wave in Strasbourg, we decided very early in the beginning of the pandemic to do chest CT as a triage tool for almost every patient with suspicion of COVID-19. And over the course of 3 months, in March, April, and May, we did more than 3,500 chest CT. We are now in the second wave of the epidemic. We are doing not as much chest CT as we did in the first wave, but we do about 30 chest CT per day for COVID-19 suspicion. So the question is, in these patients with either suspected or proven COVID-19 in the ED, is CTPA a luxury or a necessity? And this is really an everyday issue. So our objectives for the 15 to 20 minutes to come is to look at the incidence of pulmonary embolism and venous thromboembolism in COVID-19 patients, is also to look at the potential distinctive features of CTPA in these patients, and to try to predict the risk, the rate of PE in COVID-19 patients. First of all, let's begin with the incidence. Since our research letter in radiology, there has been numerous additional publications about pulmonary embolism and COVID-19 patients. And there are more and more every day. And if you look in PubMed, you have more than 500 publications on the subject. This is really huge in less than 6 months. One of the most important paper in that regard is an autopsy finding. This was published in June in the Annals of Internal Medicine. It was from Germany. They did the autopsy in 12 patients with proven COVID-19 and with broad range of origin of the patient, 5 coming from the ICU, 5 from medicine wards, and 2 from home. and they found that PE was the final cause of death in 4 cases, which is quite a lot. They also found that venous thrombosis was present in 7 cases, so more than half of the patients. And what they state in their findings is that microthrombi were regularly found within small lung arteries and also occasionally within the prostate, but not in other organs. So from this autopsy paper, it looks like there is a specific tropism for the lung arteries for the venous thromboembolism complications in COVID-19 patients. If we look at the latest meta-analysis that has been accepted in radiology in early November, it's a meta-analysis of pulmonary embolism and DVT in COVID-19 patients that included 25 studies. So most of the studies were on both ICU and non-ICU patients, and the total of patients was really high because it was more than 3,000 patients. So what have they found? They found that the reported incidence of PE and or DVT ranged from 0.7 to 57%, so a wide variability between the studies. The pooled incidence of PE and or DVT was 16.5%. And the author raised 3 major points that I would like to share with you. First of all, the difference between ICU and non-ICU patients. The pooled incidence of PE in ICU patients in this meta-analysis was 24.7% compared to only 10.5% in non-ICU patients. So this difference is highly significant, and this is something that we also found in our department in Strasbourg, where our colleagues from the ICU published this series of 150 cases, and we had 25 pulmonary embolism, 4 strokes, 3 thrombotic occlusions of ECMO lines, 1 acute limb ischemia, and 1 mesenteric ischemia. So a wide range of both arterial and venous embolism. Second point, which is important, it is the difference between COVID-19 patients and non-COVID-19 patients. So if you take ICU patients, the incidence of PE in ICU patients with COVID-19 is, as we saw, 24.7%. And if you compare to the incidence of PE in ICU patients without COVID-19, then the reported incidence is between 1.3 and 7.5%. So a significant increase of the rate of the incidence of PE in patients with COVID-19. And this is also something that we witnessed in our paper because we matched our 150 ICU patients with 145 non-COVID-19 ARDS from prior years, and the odds ratio for PE was 6.2. So definitely a very significant increase. So this is true in ICU patients. The question is this also true for emergency department patients, so patients that are not under mechanical ventilation? So in the literature, I found only one paper that suggests that there is no difference between COVID-19 and non-COVID-19 patients. This is this paper that was published in July. It's quite a good paper because it's a retrospective study, but from multiple centers from different countries. And what they say in their in this paper is that in ED patients who underwent CTPA for suspected PE, of course, COVID-19 was not associated with an increased probability of PE diagnosis. Okay, so it's a bit complicated, but what have they done? They have included 26 sites over different countries. They've looked at more than 3,000 patients who underwent CTPA for suspicion of PE between February 1st and April 10, whatever the positivity of PCR for COVID-19 was. So in the end, about 1/3 of patients had COVID-19, and they compared the rate of PE in the group with COVID-19 and the rate of PE in the group without COVID-19, and they found 50% in both groups. So their conclusion is that for ED patients, there is no difference. But we all know that during the first wave, the people that came to the emergency department were not the usual emergency as you saw it usually. It was very, very different. And we all know that in whatever recent contemporary series of CTPA in ED, the rate of positivity is never 15%. It's more between 3 and 7% maximum. So I think that the conclusion of this study might not be as definite as the authors would like to. And really, when you look at the numbers, 15%, it's definitely in line with what is published in the literature for COVID-19 patients out of ICU. Third point is, do we have a difference between the rate of PE and the rate of deep venous thrombosis? And yes, because in this meta-analysis, DVT was present in only 42% of PE patients, versus usually you have associated DVT in more than 60% of patients. And this is also something that we witnessed in our hospital, and our colleagues from cardiology published this letter about 289 consecutive COVID-19 patients in medicine wards, so not ICU, medicine wards. VT imaging was done in 100 patients. We found PE in 42%. So about 15% of the whole cohort, and we found DVT in only 15 patients. So it looks like in COVID-19 associated PE, DVT is not as frequent as it is usually. So this was for the incidence of pulmonary embolism in COVID-19 patients. So now let's go to our second objective, which is the potential distinctive features. So regarding the acquisition protocol and all the technical requirement, there is no specific technical requirement for PE in COVID-19. You just do your regular CTPA protocol, whatever you use in your department. So I've put the protocol, the acquisition protocol that we are using in our ED machine. Whatever you use the regular CTPA protocol, there is absolutely no specificity for that. Same thing for the reading and the analysis. There is absolutely no specificity in how you read the examination or how you analyze the pulmonary arteries, except for the analysis of the lung parenchyma. This is COVID-19, and we had numerous publications that said that the evaluation of the extension of the lesions is correlated with the prognosis and with the risk of subsequent ARDS. So I think this is considered good practice to follow the guidelines and to at least visually estimate the extent of the disease compared to the whole lung parenchyma. And in our experience in Strasbourg, over about 500 or a little less than 600 patients, we found that if it was below 25%, the risk of ICU death was relatively low. If it was above 50%, the risk was extremely high. So there is definitely two thresholds here, and this kind of evaluation is important also for our ED physicians that are taking care of the patients. There are also no specific findings of PE in these COVID-19 patients. The question is, do we have in-situ thrombosis or do we have regular pulmonary embolism? In favor of in-situ thrombosis, we have, as we saw before, the low rate of associated DVT compared to the usual rate in standard non-COVID-19 PE. We have also a higher rate of peripheral PE, and there is also this observation that most of the PE are located where the lung lesions are. Okay, let's go to the third and I think most important part of our topic today is the potential predictability. And indeed, the major current clinical question is, when should we do a CTPA? So ideally, we should not CTPA everyone. We should focus on where it matters. Ideally also, we should not do double work. That means that we should not do non-enhanced CT, then afterwards CTPA. And well, of course, if possible, not between midnight and 7 a.m. So there is one easy answer for ICU patients. We've seen that in ICU patients, the rate of PE is extremely high, about 25%. And if you have ICU patients with COVID-19 and with worsening of symptoms, then CTPA should always be considered and done if possible to look for pulmonary embolism. There is also another clinical situation where the answer is not as easy as before to answer, and it's the problem of outpatients. And most likely, CTPA is not useful in mild symptoms in patients that are with COVID-19 that are managed outside the hospital at home. And basically, it's the same for non-enhanced CT. And in the guidelines, chest CT is indicated only if you have significant symptoms. And significance usually means managed in the hospital. And now we get to the core of the question, the emergency department. So people that come to the emergency department with either proven or suspected COVID-19, of course, they have concerning and significant symptoms. And the question is, should we do CTPA in these patients? And the answer is, we don't know. And there are two scenarios where CTPA might be useful. First, in case of discordance with plain CT and the clinical status, and second, in case of highly elevated D-dimer. So the first case is you decide to do regular non-enhanced low-dose chest CT, and you find very little or very moderate lesions, and the clinical status is concerning, then you might consider adding CTPA to look for additional P to explain the clinical status. Second scenario is in case of highly elevated D-dimer, and the problem is highly. And in the radiology meta-analysis, there were 11 studies with dedimer levels, so about 500 patients. And as you can see, the results were varying, and it was difficult to find a definite threshold. And the authors, and I think that's extremely interesting, they report the diagnostic performances of two thresholds, 500, 100, 1000. And what we can see is for 1000, the negative predictive value is really, really high in non-ICU patients, so for ED patients. And this threshold of 1000, I think, is interesting because the specificity is significantly higher than the threshold of 500, which is definitely too low. And the negative predictive value remains really, really high. So this threshold is potentially something that we can consider to use in the emergency department. And what is our current policy in the emergency department in Strasbourg? So this is our logigram. It can appear very complex, but when we have COVID-19 suspicion, so no PCR was done outside the ED, patient comes with clinical symptoms, significant clinical symptoms, and suspicion of COVID-19. If the patient has criteria for ICU, we do just low dose chest CT and then intubation and go to ICU. If the patient has no severity criteria, then we look if the patient is already under anticoagulation. If he's already under curative anticoagulation, then low dose chest CT and that's it. If the patient has allergy, has contraindication to contrast injection, that means allergy or severe renal insufficiency, we do low dose chest CT and antigenic test. If either is positive, then the patient is highly suspicious of COVID-19. If the dedimer is below 1000, then we stop here. If the dedimer is above 1000, then we go with scintigraphy because the patient has contraindication to contrast injection to look for potential PE. If both are negative, then the patient has no COVID-19 and we stop here. If there is no contraindication to contrast injection, then we do not do a low dose chest CT right away. We put the patient in the COVID area and we do blood tests and antigenic test. If the antigenic test is negative, then we stop here. If the antigenic test is positive, then we look at the D-dimer. If the D-dimer are below our threshold of 1000, we do low dose chest CT. If it's above the threshold, we do CTPA. And this is to avoid doing double, which means first low dose chest CT, and then once we have the result of the D-dimer, doing CTPA if the D-dimer are above the threshold. So this might appear complex, but in the everyday workflow, it's relatively easy to use, and our goal is to lower the amount of CTPA that are done in this population. To conclude, there is a high amount of evidence in the literature to confidently say that COVID-19 is associated with a higher rate of PE. This is particularly true in ICU patients with about 25% of PE incidence. So is doing CTPA in COVID-19 patients a luxury or a necessity? If we go to the very simple clinical scenario, it's a necessity in ICU patients with worsening of symptoms. So whenever you have a patient from ICU that needs imaging and has worsening of symptoms, always do CTPA if you can. In ED patients, in my opinion, most of the time it can be considered as a luxury, and particularly if it is done without careful selection, and if you do it in every patient. We saw that with some threshold in the D-dimer, we can orient ourselves towards a more specific and targeted usage of a CTPA in these patients. I thank you for your attention, and we can go on with the questions.